This presentation is a short overview of the role, the techniques, and the limitations of surgery for stroke. Let us start off by seeing the indications for surgery in intracerebral hematomas. The large number of intracerebral hematomas we encounter in the ER are hypertensive in origin. What are the benefits of surgery? Surgery will decrease the mass effect of the clot. Surgery can reverse or prevent herniations. Surgical evacuation of the clot, and a decompressive craniectomy can decrease the intracranial pressure. Removal of the clot has other benefits. The excitotoxicity of blood products is, to a certain extent, eliminated by surgery. We don't operate all cases of intracerebral hematoma. Very small clots are best left alone, especially if they are in deeper locations. And very large clots, where the prognosis is dismal, also probably do not merit surgical intervention. What are the surgical options in intracerebral hematoma? A craniotomy is usually required. Now, usually this is converted into a decompressive craniectomy after the clot is evacuated. This is to compensate or code for the increased brain edema, which will also cause an increase in the intracranial pressure. Minimally invasive techniques have been tried. Neuroendoscopic evacuation of clots can be done, and catheter evacuation followed by thrombolysis is also another option. Because of the controversies regarding when to operate in a case of intracerebral hematoma, the I-STITCH study, or the international study of the surgical trial in intracerebral hematoma, was conducted as a multi-centric trial across continents. The findings were published by David Medulo in Lancet in 2005. The two options were early evacuation of a clot. This is compared with medical management of an ICH. Remember that medical management of the ICH was basically the intention to treat any of these patients who deteriorated, were subject to surgery to save life. So, intention to treat, immediate evacuation, versus medical management with surgical evacuation if required. These were the two arms. There was not much benefit in an early evacuation of surgical treatment of intracerebral hematoma. However, there are some groups in which surgical evacuation has got definite benefit. A hematoma which is close to the cortex, say around 1 centimeter distance from the cortex, probably easily accessible, and clot evacuation would probably have much higher benefit. Equally important in intracerebral hematoma is the control of blood pressure. Many studies have been done, attach, interact. Most of these studies have found that systolic blood pressure maintenance below 150 strictly helps in decreasing the incidence of increase in size of an intracerebral hematoma. Remember, it is systolic blood pressure which is important when we are considering bleeding. When we are considering cerebral perfusion, we consider mean arterial pressure. The role of factor 7 was initially touted as a lifesaver. However, in the phase 3 analysis of the FAST trial, it was found that outcomes were actually worse in patients who were administered factor 7. Is there a role of surgery in purely ischemic stroke? Yes, if the ischemic stroke is large volume, It often results in a condition called a malignant MCA infarct, where the large volume stroke swells up, resulting in an ICP crisis and herniation. In these situations, surgery is a lifesaver. Decompressive craniectomy can decrease the mortality from around 70 to 80% to about 20%. Many multicentric studies were conducted in Europe and in the US. All of them have concluded that a decompressive craniectomy, allowing the infarct to expand outwards rather than pressing upon the core brain, will save life. Decimal, Destiny, and Hamlet are three European studies which studied this. No discussion on brain bleeds, spontaneous brain bleeds, will be complete without a discussion of aneurysm bleeds and, of course, also AVM bleeds and secondary bleeds from certain vascular tumors. What is the role of surgery in an aneurysm bleed? Aneurysm bleeds, as we know, are subarachnoid bleeds. Mostly, a few of them might produce intracerebral hematomas, especially in the case of MCA aneurysms. So here the aim is not to evacuate the blood, but it is to prevent rebleed. Rebleed from a blood aneurysm is usually fatal. So in a good grade aneurysm, early control of the aneurysm to prevent rebleeds is mandatory. Why do we not prevent bleeds in poor grade aneurysms? That is, a patient who has got very poor GCS or is morbid after aneurysm rupture. The reason why we do not operate on these cases is that the outcomes in these cases are usually poor. And many of these patients, even if rebleed is prevented, will have vegetative or a dependent existence. So the primary aim of surgical treatment in an aneurysm is to prevent a rebleed. The highest incidence of rebleed is in the first 72 hours. How do we prevent rebleed? There are two methods by which an aneurysm can be obliterated. The first is putting a surgical clip at the base of the aneurysm to exclude the aneurysm from the circulation. The second is endovascular, by packing the aneurysm with coils so that a clot forms inside the aneurysm, obliterating the lumen. Both these procedures have been proven to be robust and are both standard of care. How do we choose between clipping and coiling? Clipping has certain advantages. It usually costs about 1/3 as a coiling for an aneurysm. Clipping is also allowing evacuation of clots and also clearing out of some of the subarachnoid blood. Drainage of hydrocephalus is also an option during the surgery. What are the advantages of coiling? You avoid a craniotomy, and there has been the major widely quoted study, the ISAT trial, which was published by Molyneux in Lancet in 2008, which showed that morbidity and mortality of coiling of aneurysms was better than superior to the patients who had undergone surgical treatment. However, it all depends on a center's experience. It also depends on the surgical experience of the operator. Some aneurysms, like MCA aneurysms, are still probably better clipped. And it is always possible to take up an aneurysm for surgery at any time of the day without having the full support of a cath lab. So both coiling and clipping are skills which should be available in a large volume center, and both coiling and clipping can decrease the incidence of rebleed and increase the chance of life in a person who has had a ruptured aneurysm. Remember that 2 to 3% of the population has an unruptured aneurysm in him or her. It is when an aneurysm ruptures that a cerebral aneurysm becomes an emergency. A few highlights of this talk: intracerebral hematomas, which we encounter, are often hypertensive. Very important is control of blood pressure to prevent a hematoma from increasing in size. Hematoma evacuation is decided based on the size, side, and site